Well, this is so exciting to see so many people here gathered to hear about the really incredible work that's happening at VCU Health. Thank you all for being here tonight. I'm Margaret Ann Bollmeyer. I'm the president of MCV Foundation, and we're so excited to be here for the 9th Discovery Series event. So thanks to those of you who have been here for 9 or somewhere between 1 and 9, and those of you who are here tonight for your first time. We're really happy to see you, and I know we have a great program in store, so I'm not going to take too much time, but I do want to thank a few special people who are here tonight. I would like to recognize the trustees of the MCV Foundation Board who are here. We have a number of trustees, some of whom have been here every single Discovery Series, and some who are here for the first time. So Roger Beauvais and his wife Ann are here this evening. Rachel Burgess, Judy Collins, and Joe Teefee in the back. George Emerson and his wife Darlene are here. I saw them earlier tonight. Dr. Susan Kornstein is here. Becky Perdue, I see Becky back there. Judy Forehand Starkey is here tonight. And of course, many of you, maybe most of you know Judy Forehand Woods Starkey, who has been one of the founders of this program, and we're so happy to see her here. And our board chair, Harry Thalheimer, is here. The lights are in my eyes, but I know Harry is over here. So thank you all for being here tonight. And I really want to thank our host committee. So when MCV Foundation started thinking about doing this Discovery Series, we started working with members of the community to talk about whether this is something that would be interesting and well received. And we formed a host committee that has really guided us throughout this whole process and helped determine the subjects, helped us select the topics, and helped us introduce us to people who would be interested in hearing about it and recruit people who'd be really interested in hearing about the topic. So I want to thank our host committee, most of whom are here tonight. Julie Baxter and Paul Dresser are here. Louise and Bob Canfield, Jenny and Charles Crone, Jane and Jim Kaplan, and Judy Forehand Starkey. So thank you all so much. We're also really pleased tonight to have 2 deans here tonight, in addition to our former dean who we'll be introducing soon, Jerry Strauss. We have the new dean of the School of Medicine, Peter Buckley, and his wife Leonie here tonight. So Peter, will you stand so people have an opportunity to come and meet you later? Thank you. Thank you for being here. I hope you'll take an opportunity to introduce yourself to Peter. We also have the Dean of the School of Dentistry, Dave Surratt, here tonight. Dave, where are you? Will you stand up as well? Back here in the back. Thank you so much for being here. So our program tonight is on the brink of discovery, innovation and treatments and cures at VCU Health. So this is a topic that we are really excited about. I'm really excited about the presentations you're going to hear tonight. And it really fits in well with something that I want to tell you about really briefly. MCV Foundation has created and is in the final stages of production of a new magazine about discovery at VCU Health. And I have to tell you, it was the Discovery Series that really inspired us to do this magazine. Because what we learned from all of you is how interested you are in the new discoveries, the new research, the new treatments, the applied research, the opportunities that people have as patients at VCU Health. And so we've started a new magazine that will come out in October. We will send it to all of you. I have a copy of the cover here to my left. It's called Next. So thinking like, what's next? What's next on the horizon? What's the next phase of research, treatments? And you're going to read about that in this magazine Next. So at the end of the evening, you'll get a packet of information and a folder, and you'll get a little bit more information about the magazine Next, and look for that in your mailbox in October. I also want to tell you something that's very local and just to keep you updated. Many of you know that VCU Health has a cardiology office here in Williamsburg. That office is currently located on Professional Drive. We've had some questions tonight about whether we've moved or in the process of moving. And while I understand that there are plans to possibly move that office at some point in the future, it has not moved. So for any of you who are interested or may have a interest in the future in seeing Dr. Ellenbogen at our cardiology office or perhaps another physician, that is still on Professional Drive. And then last, I want to take a moment to say thank you to those members of the Discovery Society who have not only come and participated, because that is so important, but some of you have become members of the Discovery Society by making a donation to some area of work at MCV, on the MCV campus at VCU Health. So I just want to say thank you to those of you who are members of our Discovery Society. Now, those of you who have been here before, remember that we often start our program with a story from a patient that we show on a video. And that's how we usually start our evening tonight. But we have something much more special in place this evening. So tonight, instead of seeing a video from a patient story of someone that you've probably never met, tonight we have someone from the community who all of you know, who will be here, who's going to tell his story, and that's Bob Hirschberger. So as most of you know, Bob served for 24 years in Williamsburg as the executive director of the Greater Williamsburg Chamber of Commerce and Tourism Alliance. And he has a personal story that he wants to share with us tonight, so I want to welcome Bob.
Thank you, Margaret Ann. We attend these Discovery Series programs and hear about the outstanding work that VCU Health is doing through its medical research and practices to enhance patient care and survivability. Sometimes I wonder if we're hearing science fiction or reality. At a previous program pertaining to the heart, Dr. Mary Ann Puberty described the Arctic cooling procedure designed to lower the body temperature to 92 degrees to prevent and reverse neurological damage and even death for those experiencing a cardiac arrest or other disease. Slightly more than 5 months ago, I experienced a cardiac arrest while exercising. Once revived and stabilized, I was flown to the Poly Health Center critical care unit at VCU Health, where I was administered this procedure and received a bypass operation a few days later. Normally, the chances of surviving an out-of-hospital attack such as this is less than 5%, but the Arctic procedure changes the odds. Tonight, I'm here as a testimony of Dr. Puberty's clinical research and care, as well as the medical assistance I received from the many dedicated professional caregivers treating me throughout the entire process. I appreciate the opportunity to share my experience with you this evening, and as an expression of our gratitude, my wife Margaret and I would like to make a further donation to further help the research Dr. Puberty and her team are doing at VCU Health. And would Harry and Margaret Ann please come forward? With a lot of gratitude, thank you very much.
Thank you, fantastic. Thank you. Fantastic.
Bob, thank you for sharing your story. It's inspiring, and thank you for sharing it with us tonight. Thank you for being here. So now, I think it's time for us to start the Discovery Series. And I want to introduce our MC, our organizer, really one of the people who helped found this series and who has been a guiding force since we started, Jerry Strauss. Many of you know Jerry. Yeah, go ahead. Thank you. Many of you know Jerry as the former dean of the VCU School of Medicine. He served as dean for 11 years. He stepped down very early this year. He is still at VCU Health, we're so happy to say, continuing his research, as he is actually one of the foremost researchers in the School of Medicine, with publishing over 300 scientific articles, but holding 12 U.S. patents. His research is in the area of reproductive medicine with a focus on the genetic disorders that affect infertility or fertility and pregnancy outcomes. And we're just really thrilled that Jerry has stayed on at VCU Health as guiding this important research. But we're also pleased tonight that he's stayed on helping guide this Discovery Series, helping us organize our event tonight, and doing the really important role of serving as MC. So Jerry, thank you for being here tonight. And now I'm going to invite the other doctors on the panel to come forward, and Jerry will provide more in-depth, he will provide introductions for our physicians. So we can start with Dr. Richard Marconi, Dr. Barry Fowler, and Dr. Kathryn Holloway. If you all will come forward, and we'll start our evening. Thank you so much.
Thank you, Rich. Dr. Fowler. Good evening, Williamsburg, and thank you for bringing us back. We love these events, and it's wonderful to see the turnout that we have tonight. And I hope that we will deliver in this 9th Discovery Series a unique experience for you. It was about time we did a Discovery Series about discovery, you would have thunk. And that's what we're going to be doing today. One of the important missions of an academic medical center is discovery and application of those discoveries to patient care. This is a process. It's not something that's easy. It takes passion and persistence. And I've asked my colleagues, who I'll introduce in a second, to tell the story behind their discoveries. And they've each made very important discoveries that will change the way that we promote health in the United States and treat serious illness. I'd like to say that us researchers always have those eureka moments when the intuition and the insight immediately appears. That's not the case. You'll hear about things that have been percolating for decades before they've reached fruition. And that's a testimony to the passion, as I told you, but also the stick-to-itiveness to the people who are going to be talking today. Some of these discoveries are totally novel, transformative. Some of them are building on discoveries of others, but doing it in such a way that they've built the better mousetrap and therefore made a treatment more available and more accessible to patients. So, to my right, Dr. Barry Fowler, who's the W.T. Thompson Professor of Internal Medicine and also the director of the VCU Johnson Center for Critical Care and Pulmonary Medicine. Professor Kathryn Holloway, Professor of Neurosurgery, Professor Richard Marconi, Professor of Microbiology and Immunology. As I said, each distinguished in their own right in a very different area of science. So, let me start with Dr. Fowler. Now, he is a distinguished investigator, a clinical investigator, but some of you will also not be aware of the fact that he is also a distinguished writer of fiction. His book, Organs of Greed, was published, I think, 4 years ago?
2013.
2013, that's pretty good. I read it, he gave me a copy of it. And let me give you a synopsis, and I quote, "A gripping tale of conspiracy, lies, and the secrets of black market medicine." So if you don't like what he's talking to you tonight about vitamin C, which is a fairly mundane topic, you can ask him about Organs of Greed.
You can get it off Amazon.
So, Barry, You're a critical care physician, distinguished investigator, clinical investigator. Would you tell us the story of your passion and your discovery about the beneficial effects of high-dose vitamin C?
Okay. Well, I became an active assistant professor attending at VCU in 1982. And I was thrown to the wolves in the medical respiratory ICU. And over the years, as the studies kept multiplying and multiplying to treat patients with bacterial and fungal sepsis, and the mortality kept rising, and me personally having to spend time with family members to talk about somebody who was not going to survive. Sort of looking at the perspective of over $2 billion that have been spent treating over 15,000 patients in formal sepsis trials with no therapy. We began tossing around the idea of using vitamin C in the laboratory. The initial experiments were related to something with heart attack, that we were dealing with a model in the mouse, working with cardiologists with creating a model of heart attack. And we were molecularly manipulating the mouse to prevent the heart attack. We wrote up our results, sent it to a journal, and they liked it. They went crazy about it, but they said, in the animals that you are treating, we want you to abort the treatment. And I'm working with some geniuses in the laboratory. One of the colleagues found that ascorbic acid could be the answer to the question that this person who was reviewing this article found. We did some additional experiments. The article got published. The notebook went back up on the shelf. And about 3 or 4 years later, Dr. Strauss had moved us to a different laboratory. That same investigator walked into my office and said, hey, this protein that we were looking at in the experimental animal has been found dramatically elevated in human sepsis. Notebook comes down off the shelf, and we started preparing some studies in a mouse model of sepsis. And we started, I can remember it like it was yesterday. It's 4 o'clock in the afternoon. We're injecting the animals to make them septic. And in this cage are 5 mice, and in this cage are 5 mice. These mice are septic with no treatment. These mice are septic, and 40 minutes later got an intraperitoneal injection of vitamin C. Lights in the laboratory go off. Come back the next morning. Everybody in this cage was dead. Everybody in this cage was running around. Wow. So time went by. We started a number of organized studies, and one thing led to another. We're up to now 13 publications on the mouse model. And the same guy walked into my laboratory one day and he said, Fowler, this has to go over to the hospital now. This is now going to be your baby. So we wrote an IRB, Institutional Review Board, and we started a limited safety trial in the medical ICU, medical respiratory ICU at VCU, of people who were severely septic. And we used the dosage that we had given the animals. We didn't know whatever dosage to use, so we gave that same dosage, which is about 15 grams of intravenous vitamin C, to patients with severe sepsis who were otherwise dying, multiple organ failure. We carried the study on for a year, and the results of the study were dramatic. The high-dose vitamin C patients that we treated, and this was published in 2014, the amount of organ failure, and that's one of the things that critical care doctors have to focus on, is how many organs are failed: lung, heart, gut, kidneys, liver. The amount of organs failed in our high-dose treatment patient dramatically improved. So we published the results. It it appeared in Journal of Translational Medicine. And right about that time, the NIH put out an announcement, and the announcement was novel therapies of lung disease. And for all of my career, I had been studying how sepsis leads to acute lung injury. Too complicated to explain now, but septic patients often develop acute respiratory distress syndrome. The mortality is about 40%. In fact, if you can think about the number of people who are dying in this country every day of sepsis, someone across the country dies every minute of every day, year after year. So we wrote up an NIH grant, and the NIH, this guy kept seeing me in the faculty dining room every morning. Have you heard from the NIH yet?
It's a dean.
He was my cheerleader. And finally, we were awarded $3.2 million to do a phase 2, limited small phase 2 trial. $3.2 million when you're spreading it across multiple medical centers is not really a lot of money. So we teamed up, VCU is the lead center, the Cleveland Clinic. I had critical care friends at these places, Cleveland Clinic, Medical College of Wisconsin, and the University of Kentucky. And 4 years ago, we started enrolling patients in a trial blinded. And that's the only way that you can test if something is effective. It has to be blinded. You cannot know what the patient is receiving, and it has to be tested against a placebo. And the placebo is simply just sugar water. So I was just notified today that we are 7 patients away from completing the trial. We originally proposed 170 patients. It's taken 4 hard years, and as Jerry said, 4 hard years of a lot of red tape. The NIH is on your back every week. They want to know, are you meeting your enrollment? We had originally proposed 170 patients, which in terms of sepsis trials is very small. Sepsis trials that have come down in the 2000s, multinational trials enrolled 19,000 patients. So we're close to the end. I've had many phone calls from the cardiac surgery intensive care unit and patients with highly acute lung injury that I remember my wife and I, it was the night before we were going to the Outer Banks on vacation, and I'm about 2 glasses of Chardonnay into my evening. And the phone rings, and it's the chairman of surgery, Vig Kasarajan. Some of you in the room may have met him. He says, "Barry, this is Vig." And I know him as a friend. Okay, and the chairman of surgery is calling me at home, and he told me the story of a young woman who was 20 years old, junior at JMU, who was in Tuscany staying with a family with 3 college chums. And while she was staying with this family, one of the family members came home from Morocco on a spring vacation with a severe respiratory infection. And these girls were around this sick family member for a couple of days. Anyway, they took the bus to Milan to the Charles de Gaulle, and then launched back to the United States. And about 3/4 of the way back, as they were approaching the U.S. mainland, this girl gets increasingly short of breath. One of the flight attendants from this airline, I think it was KLM, walks by, and this girl is blue. And so she gets the girl up, takes her to the back of the plane, puts her on 100% oxygen. They land at Dulles. EMS takes the girl off the plane. They take her to a very close by emergency room, Inova Fair Oaks, where in the emergency room she was immediately put on mechanical ventilation. Was admitted to the ICU, and over the first 6 hours, the guy who was the critical care doctor up there, who is a very good critical care doctor, could not oxygenate or ventilate her. So somehow he had Vig Kasarajan on speed dial. He calls Vig. They activate the ECMO team. ECMO helicopters up to the airport. They put her on ECMO and then helicopter back to the cardiac surgery ICU, and that's when I got my phone call. Well, I want her to be in your study. And so if she had come into my study, she could have gotten placebo. And I'm looking 2 glasses of Chardonnay into my evening. I'm thinking, well, I've got 48 hours to put her in the trial, Vic. I'll just come in tomorrow morning. And these were his words. You don't understand. I want her to get vitamin C. So she was in severe respiratory failure. He hands the phone over to the anesthesia intensivist. I told him the dose of vitamin C. It's 50 milligrams per kilogram intravenous, administered over 30 minutes, light protected tubing because vitamin C will oxidize. And it's infused over 30 minutes every 6 hours for 96 hours. As it turns out, she had acquired enterovirus D68, which is a deadly virus, has been reported many, many times across the world, causing respiratory failure and acute lung injury. And we gave her the vitamin C. 7 days later, she was taken off of ECMO and taken off the ventilator to 2 liters of nasal oxygen, was transported by ground ambulance back to Inova, where she stayed on 1 liter of nasal oxygen, then went home, and came back 2 weeks later to see Dr. Lepler, the critical care doctor, got a chest x-ray that was totally normal. So the significance of this was a report, as I was writing this case report up, the significance was this, and this girl was 20 years old. The report came out of the University of Illinois of another patient with enterovirus D68, acute lung injury, who was 29 years old, was on mechanical ventilation for 42 days, tracheostomy, percutaneous gastrostomy, finally made it out of the hospital by tracheostomy on high flow oxygen at day 55. And we had this girl, we saved her life. We had this girl out of the hospital on day 7. ECMO saved her life, but we're all convinced that vitamin C saved her life. So in the sepsis trial that we're doing, we don't know who's getting what. But I've had some interesting interactions with ICU nursing who are incredible at VCU. And I'll be working on the computer there at the nursing station in the medical respiratory ICU. One of the senior nurses will come out of the room, your patient's getting vitamin C. And I will say, okay, and you know that because? Well, she was in shock an hour and a half ago, and she was on all these vasopressors, and now I've almost tapered them all off. So I'll end up by saying, when you raise the plasma levels of vitamin C very high, as we're all having a normal diet, our plasma level is about 60 micromolar, which is very low, but that's what it takes because we can't synthesize vitamin C. Animals can synthesize boatloads of vitamin C. So we raise the plasma levels by giving it intravenously 3,000-fold higher. And when you get up to those high levels, and we've shown this in our model, our animal models, it's very potently anti-inflammatory. The microvascular coagulation that occurs in sepsis, it will totally abort. In a girl like we had in the intensive care unit where her lung was basically white, full of fluid, it causes the alveolar air spaces of the lung to recover, and the lung has a way, when you're born, to empty alveolar fluid and to get it back into circulation so the lung dries out. And we observed all of that, and we've now reported 3 cases just like this. So we're 7 patients away from being through with the trial. We're going to be analyzing the data coming up soon. Some of you may have heard about Dr. Merrick at EVMS, who we were having some trouble with our trial with enrollment a couple of years back. And I called, he's chairman of pulmonary at EVMS, and I called Paul Merrick, who I knew just peripherally. Hey, Paul, how would you like to come into this trial that we're doing, giving vitamin C and sepsis? And these were his words. I'm sorry we can't participate in your trial, because ever since you published your paper in 2014, that's been our standard of care. And so we were on a podium together out in Corvallis, Oregon at the Linus Pauling Institute a couple of weeks back. Every other year, they have a big vitamin C, vitamin E, vitamin D summit out there. And he was telling the audience, you know, all of this originated at VCU. So I'm happy to say to all the audience, this was invented at VCU. Mm-hmm. And if this turns out to be a therapy, the last therapy for sepsis that was taken off the market by the FDA was $34,000 for a 4-day treatment, which is cheap in terms of medication these days, you know. But we can treat a patient getting the drug, pharmacy mixing the drug, storing it in the ICU, nursing administering the drug for less than $1,000 for 4 days because vitamin C is so inexpensive. So you would not believe how my email is burning up and the phone lines are burning up. Calls from critical care doctors around the country wanting to know about this therapy. So what may happen in the future, antibiotics, fluids, medicines to support blood pressure, typical ICU care will go forward, but vitamin C maybe will become an adjunctive therapy that will save lives. This has been my supporter right here.
Thanks, Barry. And you know, Barry mentioned Linus Pauling, and for those of you who have followed science in the past, you'll know that he is was a two-time Nobel laureate. And one of his ideas early on was that vitamin C could cure cancer. And the Linus Pauling Institute, which was formed after his death, was basically devoted to the study of vitamin supplementation. But the clinical trials that were done to determine whether vitamin C had any anti-cancer activity totally failed. And actually, Dr. Pauling was discredited based on his fervent belief that vitamin C was going to be a miracle drug, only to
And the
have a
reason,
recrudescence.
the reason for the failure.
It wasn't given IV.
It was given orally.
And not high enough
So
concentrations.
someone can take 6 or 7 grams of vitamin C if you can tolerate that much, but the plasma level will never get above 150 or 200 micromolar, whereas we're getting 3,000 times that, giving it intravenously.
Yeah. So taking a concept that had failed, persistently pursuing it from animals to human experimentation, that's the pathway of discovery. Doesn't always turn out to have a happy ending. In this case, it did. So, Richard,
Yes,
now
sir.
for something completely new and different. Dr. Marconi is an expert in Lyme disease. Yes, I know there are people in the audience who have had their close encounters with Borrelia Bergdorferi, which is the main bacteria that causes, at least in this part of the world, Lyme disease. And for those of you from New York, it's not named after Bergdorf Goodman. It's a spirochete. It's the same type of organism that causes syphilis.
And periodontal disease.
And periodontal disease for Dr. Surratt. A scourge. And I can tell you, I was on vacation in Bethany Beach with my grandchildren, and they wanted to go tramp out into these fields. And of course, there were signs. This is tick infested. Please wear long pants and high socks and long sleeves, and check yourself for ticks after you've taken the trail. And of course, grandkids had shorts on. I had shorts on. We had a very intensive tick party. But Rich is working on a way to neutralize the risks of having Lyme disease through his incredibly innovative approaches to vaccine development. some of which are already in market in the community for animals, but he's working on the human vaccine, which is, of course, the Holy Grail. So, you know, I actually don't even know how you got interested in Borrelia.
It's a long story, actually.
Yeah, well, let's hear it.
Well, you know, it's hard to follow a writer. So I feel a little under the gun here to follow Barry. So I'll give you a little bit, maybe a little bit more concise version. But yeah, it's interesting that I ultimately wound up working on Lyme disease because I'm a kid from Brooklyn, New York. And we didn't have a lot of ticks in Brooklyn, at least not that I remember. So, you know, my path to getting involved in studying Lyme disease and other spirochetal infections really began when I was doing my first postdoctoral training stint at the Roche Institute for Molecular Biology in Nutley, New Jersey. And at that time, every time you turned on the TV or you looked at Newsweek magazine, there was something about this new mysterious illness that was showing up in the population. And this was in the mid-1980s. And it came to be known as Lyme disease, named after Old Lyme, Connecticut, where the condition was first described. But again, being a postdoc, you have to be very opportunistic because you're sort of plotting your path forward for where you're going to go with your research for maybe the rest of your life. So looking at what was going on in the medical field at that time, understanding there was this new infection, so to speak, that was coming forward, it seemed like a good opportunity. So it was really kind of that simple. I started reading about Lyme disease and decided this is what I want to work on. And then the next question is, where am I going to work on it? So in the United States, there were really two major labs that were working on Lyme disease. One was in the state of Texas. The other happened to be in this beautiful mountain town in Montana called Hamilton, Montana. So I looked at those two options and I thought it was pretty easy. Hamilton, Montana looked like a great place to me. And at that time, a gentleman was working there. His name was Willy Bergdorfer. And Willy is, of course, the gentleman that the bacterium is named after. As Jerry pointed out, it's called Borrelia Bergdorferi. So that seemed like a great opportunity. So I made my pilgrimage, so to speak, to Rocky Mountain Laboratories and started working on Lyme disease. And really, for the first 15 years of working on Lyme, I was really working on just basic science. And I really had very little interest, to be honest with you, in thinking about translational applications of what we were doing. There's sort of this mindset that comes into academics at the basic science level where you almost try not to think about commercial aspects of things. It's a funny kind of way of looking at things, but you want to be pure to your science. But after a while, we realized, no, there's things we can do here, and there's contributions we can make. So when I moved to Virginia Commonwealth University in 1994 and set up my lab there, we really started full force on developing our Lyme disease program. And it was about 10 years after that we really started thinking about the idea of developing a vaccine for Lyme disease. Because the one thing that was consistently bothering me is our best method of prevention of Lyme disease at that time, and frankly still is, was this idea that if you just did a quick tick check when you came in from outdoors and you stuck your pants in your sock and you avoided tick exposure, that Lyme disease would not be a problem. Well, that turned out not to be the case because Lyme kept continuing to grow as a problem. Now we see somewhere between 300 and 600,000 cases a year in the United States alone. Of course, we have it in Europe and parts of Asia as well. So it doesn't take much of a scientist to figure out that there's got to be a better way to prevent Lyme disease than tucking your pants into your sock. So that's what brought us into the vaccine world. And a lot of folks had tried to develop a Lyme disease vaccine. There, in fact, was one on the market for a couple of years. After 3 years, it was pulled. It was largely an unsuccessful vaccine. It wasn't a real receptive marketplace to developing a vaccine. But nonetheless, we recognized that we felt it would be with time. So we plotted forward at a time when there wasn't a lot of enthusiasm for a Lyme disease vaccine. And the challenge, really, in developing a vaccine goes back to these sort of amazing creatures that cause Lyme disease, which are these spirochetes that Jerry alluded to. These are really remarkable bacteria. They look like a corkscrew. And if you turn a corkscrew in the air, it goes nowhere. But if you put it up to a cork and you turn it, it starts to drill. And that's what spirochetes do. They get passed from a tick into an individual. They drill their way through the body very efficiently without much trouble. They're able to hide and they're able to avoid being targeted by our immune system. So getting rid of a Lyme disease infection is really quite a difficult thing. And we realized that prevention was really where we needed to go. We needed a better way to prevent the infection. But the problem, again, with developing a vaccine is that these bacteria that cause the infection, they're remarkably diverse. They're remarkably variable. If you go out into a field and you collect a bunch of ticks, which we do from time to time, and you look at the Lyme disease bacteria that are inside of those ticks, they can vary tremendously from one tick to another. So how do you make a vaccine that will protect us or trigger our immune system to protect us against all those different versions of the Lyme disease bacteria that are out there? That was the real challenge, and that's why it has taken so long to develop better diagnostics as well as better preventative mechanisms or approaches for Lyme. So we came up with an idea in my lab that was really kind of a team effort for sure. What we realized is that we can't just take a single protein that's made by the Lyme disease bacteria and use it to make a vaccine, because it's not going to work on all the different strains that are out there in nature. So what we decided to do was to focus on one particular protein and find the important regions of it that trigger a good immune response during an infection. And then we would take those segments and take them from many, many different variants of the Lyme disease spirochetes and fuse all those segments together to make a brand new protein. So it's not a protein that's made by the Lyme disease bacteria. It's something that we actually created in the laboratory. And we call these proteins chimeratopes. And what that stands for is chimeric epitope-based protein. So an epitope is the part of a protein that will trigger an immune response. That's what you want to have in a vaccine. We called it a chimeric epitope-based protein because we took all these different epitopes and we fused them together. We made a chimeric and created this brand new protein. And certainly our goal was to take this forward into human medicine as quickly as we could. But the market conditions just really weren't there, and we had this opportunity to move into the veterinary arena. So we did that, and I think that was really important. We've developed a canine vaccine for Lyme. It's the most successful vaccine on the market. But having done that, it really opens the door now to let us move into the human markets. We've proved that this can work. So that's kind of the path that we followed. And I'd also like to mention that we've used the same technology to develop a new test for Lyme disease. If any of you have dealt with Lyme disease, and I'm sure that some of you have, you know that the idea of diagnosing Lyme disease can be very, very difficult. It's not because Lyme is some bizarre infection. It's a very interesting infection, but it's not that different from other bacteria.
As long as somebody else has it.
As long as somebody else has it. But the point I'm trying to make is that to diagnose it, you need to be able to account for all this diversity that exists in these bacteria. So using these chimeratope proteins that we created, we found that they were also really good as a means of detecting an infection with Lyme disease. So that led to the development, commercialization, licensure of a diagnostic test for Lyme as well. So we have a human diagnostic test, we have a canine vaccine, and it would be really sort of the trifecta to hit the human vaccine. And we're really excited about that, and I have a great team of people that work with me to do that, and that's kind of how we got where we are and where we want to go.
Thanks, Rich. That's it's a wonderful story. Rich and his team have been able to put some science that is understandable into the biology, pathophysiology, prevention, and diagnosis of Lyme disease, which has been sorely needed and a major contributor. And I'm glad that he commented, and Barry did too, and I would be remiss not to mention the fact that in addition to their brilliance as scientists and investigators, they are also outstanding mentors. Matter of fact, Rich has won an Outstanding Mentor Award. You get one tomorrow. They're training the next generation of investigators to carry on this work, which is absolutely one of the most important things we do. So, let's get cerebral. Cap Holloway, I think, is known to some of you. She is one of the world's leaders in neuromodulation through deep brain stimulation, or DBS. And her story is one of those building the better mousetrap and have the world beat a path to her door. And again, a story of persistence, the happy ending. Yeah.
Thank you so much. And yes, it is very intimidating to sit in this audience, have heard these stories, and then I'm going to tell you my story about tinkering with things that other people made and trying to put them together to something more useful. But I can tell you that it was really a story of love and hate. And that's always the good basis for a novel, right? So I have this great love for what I do. I am very privileged to be able to take people who are devastated by a neurologic disease and give them back some semblance of health. And I'm grateful every day that I get this opportunity. I do this with deep brain stimulation. So it's this wonderful tool that we can put in the brain, and all we have to know is the right place to put it in the brain, and then we have to get it there. So, you know, when your general surgeon wants to go do something in your abdomen, he just opens it up or sticks the scope in there and he looks around and he can see everything. Well, when you open up a hole in the skull, you're not seeing anything except a little bit of pink. And that whole brain looks the same. It's just a big mass of gelatin pink. So how in the world can you say, this is where I want to go? I'm looking for circuits in the brain. And so there's been a lot of discovery that has gone into understanding how those circuits are linked up and where are the important nodes that we can go to affect these diseases. But the hate part comes in with how do we get there? So when I was trained to do this, the way that we got there was we put this big barbaric metal cage and bolt it to the patient's head, bolt the patient to the bed, and then operate on them while they're awake. Now, that's horrible, you know? And it looks like a medieval torture device. That is my pet name for a stereotactic frame. And so I said, this surgery is beautiful, it's elegant, the results are fantastic, the neurophysiology you have to master in order to do it is elegant. Why are we using this medieval torture device? And so right about the time that I was doing this, so I started doing this surgery in 1997, a new tool came out in neurosurgery, which is called frameless stereotaxi. And it's like GPS for the brain. So we're going from this medieval torture device, which I would liken to an astrolabe, you know, the thing that they used when they sailed with Columbus across the ocean. That's the equivalent. And now we had something that was GPS for the brain, and I'm still stuck with the astrolabe. And I'm doing the most elegant surgery there is. So that didn't make any sense. But the reason for the difference is I need the utmost accuracy. All of my partners who do all sorts of other surgery are grossly inaccurate compared to what I have to do. So my stereotaxi could get me within 2 millimeters of where I wanted to be in the brain. And that was not close enough. I still need some techniques to examine the patient during the surgery to see if I'm in the right spot. So that 2 millimeters got me close, but by examining the patient, turning on the stimulator, seeing how they react, or by listening to the brain cells as I pass my electrode down through the brain, I can tell where I am. And so this is why you have to have the patient awake. you know, if you're asleep, your brain's asleep, it's not doing anything. And so this is how we fine-tune that accuracy. Well, if I went with the traditional frameless stereotaxi or GPS for the brain, I'd get a centimeter away from my target. That was not going to do the trick at all. So I started to explore, well, there's got to be some way to make this more accurate. There has to be some way that we can use this tool and get to a much more elegant solution. And so I, you know, went to meetings, I talked to people, I searched around, and no, everybody thought the frame was terrific. I don't know, I have some crazy colleagues, but they persisted in saying this is the tool that we've got to use. But one meeting, I started talking to a guy who worked for a company. It was a small company, but they actually had made the device that could hold the deep brain stimulator in place. When we're all done with the surgery, it would clip it in place and hold it there as an implant. And they were thinking the same thing as I was. They had tried doing this. They had something that was a biopsy device, and they had tried to just, well, let's just throw it together and see if it works. And it was a disaster. That it didn't have the accuracy. And I said, no, let's not do it that way. Let's very carefully change the device so that it does what we need, and let's measure it in a way that we will be able to not only get that same accuracy, but will prove it on any individual patient. Because we knew already, we did the first preliminary studies where we just took a plastic head and we pointed things with this device. And we knew that actually not only did we have the same accuracy as the frame, but we actually had a little bit better accuracy. But now we're going to bring it to patients. We have to be doubly sure. And so actually we did something kind of crazy. We put stereotactic frames on the patients, but then we actually used our new device to guide the probe to the right location. But before we actually put it in, we made sure that it matched the same trajectory as the stereotactic frame. And so that way we never compromised patient safety. We had excellent accuracy data. And this was so critical, not only for these patients, obviously that's my most important thing when I'm the operating surgeon, but also because I am talking to a community of skeptics. They're diehard fans of this frame. Their opinion of the frameless stereotaxi is very low, and I've got to convince them. And so we did all these studies. We proved that we could do it as accurately. And so now this little company is about to be bought up by the big giant. Medtronic is coming in, swooping in, the white knight, and they're going to buy up the company. And the people in the company said, hey, you know, you were a key part of this. Do you want a piece of the action? And to this day, my husband kicks me every time I tell this story because you know what I said. This is too controversial. If the lead author is in the pocket of the money, then nobody's going to believe it. So my husband thinks I was very foolish, but I will tell you that I really do think that made a big difference going forward. And so this technique now started to be used at multiple centers. It started to spread around the country. And, you know, when I saw an article published by one of the great people in our field, Kim Burchell in Oregon, and it was talking about using this device called the Next Frame. And the article wasn't even about that. It was about some other technique he was doing. I knew that finally this was accepted. It was not the subject of controversy. It was a standard tool, and everyone had accepted it. But it took 10 years, and we just kept working at it. But we actually didn't stop there. Then since I had stolen some other instruments, I decided to steal a spine imaging instrument, something that when you're putting big pedicle screws in the back, you can take a intraoperative CT. And I said, well, you know, a deep brain stimulator is not that different from a pedicle screw. And so we started to take pictures of that. And so now we have coupled this nice device that allows the patient to move around during the surgery. They're very comfortable. They're not even aware of it because it's about the size of a styrofoam cup sitting on the top of their head. They don't even know it's there. If they want to move around and get comfortable, they can. And now we've added to it imaging so we can see the electrodes in the brain as we're listening to the brain cells and test stimulating them. And this is allowing us to understand so much better what's going on in the brain. So much that our next steps, we really want to start to develop the brain-computer interface. So right now, we're putting in a dumb signal that is, I would liken it to saying, just shouting really loud, stop, you know, and that's all the brain hears is stop. But trying to talk to the brain to tell it in a sentence to do something, that's much more complicated. But by listening to these cells, listening to the cells that they're talking to on the surface, looking at that all on a CT scan, having the patient comfortable so they can do a task, now we are starting to build an understanding that will allow us to talk back and forth. And we hope that this will allow us to start to treat a more difficult disease than the Parkinson's, dystonia, essential tremor we already treat. What we really want to tackle is the epidemic that is approaching in Alzheimer's disease and dementia. And we hope that these type of approaches will make a difference. And I can do this, it's very important to say, because of the incredible collaborators that I have at VCU. Mark Barron, who is in neurology, runs a lab that is critical in developing the understanding of this. I have colleagues in engineering and in epilepsy who are all helping with this. And it's because VCU is so collaborative. There's no competition amongst us. Some of the people we're interviewing for jobs are just commenting on how remarkable it is that we can all work together. Nobody's protecting their own turf. We're all working together. So, like I say, I'm one of the luckiest people in the world to be privileged to do this. So, thank you.
I wanted to show something.
So I want to show you the love part. Jerry wouldn't let me show you the hate part, but if we can run the video, I'll show you what deep brain stimulation can do. The first video that's playing is a patient with Parkinson's disease, and he's debilitated by it. Even though he's very young, you can see how he struggles to get up, how he struggles to walk, and this is his life. He can take medicine, and it'll help him go for a little while, but then he'll end up back in this state. And so this is the type of patient that will come to see me. And so if we place the deep brain stimulators, then you can see in the second video that he is, even without any medications, he's able to pop up out of that chair, and he can now run circles around himself in this video. This is the power of PBS.
Thank you, Cap. Now, I always try to throw some curveballs at my friends in the panel. We're talking about the future. So I want each of you to tell me what's on the horizon in the next 5 years. What important medical breakthrough is going to happen in your field, or you're going to make, that's going to change the way that we treat a disease or diagnose a disease? Barry.
Okay. Well, we're using vitamin C in several other ways. We right now have a trial going on at VCU. Many of you in the audience may have had a procedure called atrial ablation for atrial fibrillation. And the aftermath of that procedure is usually accompanied by 2 or 3 days of painful pericarditis, which is the membrane around the heart. And when it's inflamed, it causes severe grinding pain. And so we are testing vitamin C to reduce the inflammation of the pericardium. This is also a blinded trial. It's being done by electrophysiology with Ken Ellenbogen and with Jay Conneru. Some of you may know that name. And what we're doing is another blinded trial where standard treatment versus standard treatment plus vitamin C to determine if the pericarditis, which is very painful, the inflammation is attenuated by vitamin C. We are currently using vitamin C in a blinded way in patients coming off of cardiopulmonary bypass after open heart surgery to determine if vitamin C can attenuate the number of ventricular and atrial arrhythmias that come after that. We have a small trial going with VCU bone marrow transplant. The aftermath of bone marrow transplant or stem cell transplant, 45% of patients develop graft versus host disease, which is pretty horrible. And it's all about chronic inflammation that's brought about by the marrow fighting the patient's body once it's infused. And so a small trial going there. And then the last thing I will mention is some of you may have relatives or even children who have cystic fibrosis. And patients with CF end up in the hospital routinely 4 or 5 times a year. And those are produced by bacterial exacerbations, where the patient will develop fever, shortness of breath, infiltrates on chest x-ray. It's virtually always due to pseudomonal infection or other bad bacteria, Acinetobacter. And those patients, you know, here's a 25-year-old person who's survived to age 25, who's in the workforce, but who ends up in the hospital for 14 or 15 days with a central venous line and 3 antibiotics going in. And the question we're asking is, can infused vitamin C attenuate the pulmonary exacerbations, limit the hospitalizations, and preserve lung function? One of the things these exacerbations do when patients end up like this is that there's a slow downward grind in lung function. And what we're interested in is, can vitamin C preserve that lung function? So I think that we're discovering an old therapy like what Jerry mentioned. We're discovering intravenous vitamin C. We're discovering that a vitamin can be potently anti-inflammatory and that it could have multiple uses going forward.
Great. Rich, what's your projection?
Projection. Okay, well, you know, I think one of the things that we're really excited about is sort of expanding this technology that we've developed, which again we call chimerotope technology. And the way that we want to expand it is that I think, as you all know, ticks don't just carry Lyme disease, they can carry many different diseases. And what we would like to do, and we're funded to do this by the Cohen Foundation, the National Institutes of Health, State of Virginia, is we are going to take this technology and take our Lyme disease vaccine and incorporate into it pieces of proteins from other disease-causing pathogens that can be transmitted by ticks. And the goal of this is to make not just a Lyme disease vaccine, but a tick-borne disease vaccine. And that to me is really a very, very exciting prospect because Lyme disease is not the only tick-borne problem that we deal with. And of course, we want to take this now from veterinary medicine and of course move it into human medicine. So we're working very aggressively on that. We are also taking the same technology and working on a vaccine for periodontal disease. Periodontal disease affects 70% of the adult global population. And while most of us can afford to get care for periodontal disease, in places where people cannot, it can be remarkably debilitating. When you lose your teeth, it causes health problems, nutritional problems, many, many other things. So we're really excited about that prospect. But in a more general sense, and maybe we personally will never tackle this, but I'm really excited about the idea of making these types of combination vaccines, because what we've seen over the years is this trend of an unwillingness to get vaccinated. And I think we could address and decrease those concerns if we can give vaccines for more diseases with fewer doses. So you think about the multiple vaccines that your children got or get when they go to the doctor. Well, what if they could all be combined into, or a couple of them at least, could be combined into a single dose? That would greatly reduce the number of vaccinations that have to be given. And I think that would play a really important role in really the future of developing more vaccines that the public will accept and will take on. So those are some of the things that keep us working night and day and keep the students in my lab working night and day. And I keep them working night and day as well. But, so.
Thanks, Rich. So, Cap, you've used DPS for some other medical indications as well. Where do you see the whole field of neuromodulation going? I mean, it's a totally different approach than our pharmacotherapy, which has sort of dominated neurology.
Right. Well, you know, it's interesting. Chemistry is, you know, one of the languages of the body, but so is electricity. And so we're just using another language of the body. Neurons are all about electricity. It's about one cell sending off an electric current to the other cell saying, hey, pay attention, do this. And so I think that we really are starting to understand these, the way this works. This nucleus that I'm interested in now is fascinating. It's called the basal nucleus of Meynert, and it's about the size of a postage stamp, and it sits on the floor of the skull, just up in the brain, and it sends fibers to almost every part of the cortex, the thinking part of the brain. And when you decide that you want to remember something, either because you know, there was a food reward, there was a money reward, whatever you or an animal decides, okay, this is important, let's remember this, that motivation goes to the NBM. And the NBM, this basal nucleus, is the one that tells the brain to write it down. This is so powerful that when you want to train a rat, you can keep having them do something over and over again and rewarding them with a food pellet, or you can simply turn on the NBM and then they remember. Now, that's a cool nucleus.
Yeah. Thanks, Cap. So I would like to have a few minutes for you to pick at the panel. We're going to have a strolling supper where you get a chance to get up close and personal with my colleagues. But we do have, I think, Brian, we have a few 5 minutes, 5 to 10 minutes if there are any questions. We're getting lights in our eyes, so if you stand up and wave your hand vigorously, then we'll be able to identify you. And I think we have microphones going out there, actually, and hopefully we'll be able to answer at least some of the questions.
Hi, I'm wondering if the vitamin C therapy has been tested to treat sepsis in children.
Well, that's an important question because when we were submitting our protocol to the NIH, we had to exclude certain patient groups. And we had to exclude anyone less than 18 years of age. So what we're doing is entirely an adult study. As far as I'm aware, it has never been employed in childhood sepsis. That's something I hope will begin to evolve. What I didn't mention earlier is I've been traveling back and forth to Atlanta, and some colleagues at Emory University have been funded by a $25 million grant from the founder of Home Depot to perform a large phase 3 trial looking at vitamin C and sepsis. That's going to be an adult trial, unfortunately. I know of no research in children currently, but I think with time what we're going to see is it will begin to evolve as the safety aspect is emphasized over and over to critical care doctors, and they know they can size administration down to a certain body weight and give I have personally treated 2 or 3 PICU, pediatric ICU patients with vitamin C, 17 or 18-year-olds, at the request of the doctors using vitamin C as open label, which were reasonably successful, but no trials that I know of.
Other questions?
Another question on the same vein of safety of vitamin C. Whenever we see an ad in the TV, it always has the fine print on the bottom. These sound like very large doses of vitamin C. Are there any side effects?
Thank you for that question. Our phase 1 trial was a safety trial. And we're talking incredibly sick people. We use what is called the sequential organ failure assessment score. And its way of looking at all the body organs, 6 different body organs, and applying a number to the extent of injury. And as I mentioned earlier, vitamin C was very effective at bringing the SOFA score down. We were giving vitamin C to some outrageously ill people and never saw any adverse event. And now in the trial that I'm currently approaching the end of, we're now 4 years into the trial and we're almost done with 170 patients. We have not had a single patient stopped because there was an adverse event from drug administration. So thank you for that question.
I'm looking out. Yes.
While you are developing a vaccine for Lyme disease, the Hampton Roads area is designated as particularly prone to tick-borne illnesses. Do you have any recommendations for prevention?
So if you didn't hear the question in the back, it related to the Hampton Roads area of Virginia being an area that's particularly prone to tick-borne infections and tick-borne diseases. And the question was, do I have any specific recommendations for prevention? You know, as I sort of jokingly said earlier, the options available are pretty limited. Certainly, DEET and other things can be very helpful to impregnate your clothes with that. That certainly plays a key role in keeping ticks off the body. But there is no advanced, sophisticated, non-intuitive way right now to really prevent diseases. So I think you do have to fall back on the being very diligent in tick checks. I'll just follow that with a very quick story about my own experience with some ticks, which I always find quite exciting because I love ticks. So I was recently in Montana and hiking along the Bitterroot River in Montana, and driving back in the car, I was looking in the rearview mirror and just picking ticks off me as they crawled across my forehead. So I did my very diligent tick check, and when I got back to the hotel and threw my clothes in a corner, took a shower, came out a half hour later, and there was a half dozen ticks crawling up the wall. So I had a pretty heavy tick exposure. And the take-home message is very simply that you have to be very diligent, not only with checking yourself, but making sure you get rid of them from your clothing, that your animals are not transporting them. That's the best you can do right now. You can certainly vaccinate your pets.
There you go.
Gives a new meaning to bed bugs.
Yeah.
Dr. Holloway, you mentioned the uses of neuromodulation. I heard in the news this week the report that a woman who had been in a vegetative state for about 15 years was revived to some extent through neuromodulation. Do you see some advances in the future for traumatic brain injury patients using neuromodulation?
Yes, great question. Yeah, so that is something that is being investigated. The persistent vegetative state or the minimally conscious state after head injury is something where we think that the person is still in there but just blocked off from interacting with the environment. That's a very rare head injury that causes that. So most of the patients that are in these severe states, you can see on the scans that the brain is gone, that is simply not there. And we don't think that we can, at this point, rebuild that brain. But for the patient where it is, because if you think about it, when we go to sleep, right? Every night we look like we're in a coma, some of us more than others. So that's a state that you can be awoken from. And so perhaps there are individuals that have all the equipment still there, but they just can't be awoken. And so there has been some work to do that. Now, so far, what they have been able to do is get people who are in that state to respond a bit to the environment. Unfortunately, it has not been, that they got up and walked out. Although there are patients that have done that spontaneously. So again, proving the concept. So I think this is going to be helpful for a small select group. But I think the more exciting thing is some of the work that's being done by my colleagues in rehab medicine at the VA. They are taking a non-invasive way of neuromodulating the brain, something called transcranial magnetic stimulation. And yes, so magnets really do work. But these are very special magnets where you have an electrical current and you can force a magnetic field through the skull to the brain. And you can either activate or deactivate the brain. This is actually a standard treatment for depression. That old saying that you can't think when you're mad or cold as ice. The truth of depression is that it's really true. When you're very emotional, the cognitive portion of your brain shuts down. And that when you are using a lot of that cognitive portion, the emotional section shuts down. So this transcranial magnetic stimulation has access to the cognitive portion. And so it wakes it up, and that will treat the depression. So that seesaw is being used to our advantage because we have this device that can only reach the surface. Well, now these investigators are trying to use that on the brain that is viable but sick, as identified by something fancy called quantitative EEG. And so they're trying to recover the deficits that the patients have by waking up this portion of the brain. So I do think that there is hope for traumatic brain injury.
Cap, thank you. You've been a wonderful audience as usual. Please thank my colleagues for their presentations. And you'll have a chance to talk with them at the strolling supper.
Folks,
Barry.
Before we depart, and I realize I stand in the way of food and drink, so I only have about 25 minutes of remarks prepared, so please don't worry. I have the privilege of chairing this board, the MCV Foundation, and it is a privilege and it is an honor. And it's an honor because we have the opportunity to work with and work for the kind of people that you have the privilege of looking at, listening to, and sharing part of this evening about. Jim Kaplan chewed me out one night and said, what you've got there is a great academic medical center. People forget that. This kind of stuff doesn't happen in a hospital. It happens at a great academic medical center. And we are blessed and we are honored. And I thank all of you. I think it's fantastic and it's a privilege and it is an honor. But I think about it and I think that we are also a place where a lot of collaboration takes place. And I only think if Jerry Strauss was about 10 years younger and he was back in that room working with Barry Fowler when that was that cage of 5 mice over here and 5 mice over there. When Barry came in the next morning, there'd be 15 mice in one of those cages. Bada boom. So Jerry, thank you. Thank you. And Barry, Cap, Richard, thank you very much. Bob Hirschberger, your remarks were beautiful. Your gift, magnanimous. It means so much. Thank you. Really, really appreciate it. Thank you. For those of you here tonight and those of you who've been here before, look at this room. I mean, we've never had a crowd like this. This is unbelievable. We started this event. The panel was back there. Half of the room was full. This was all food and a bar over here. Now look. It's amazing. It's a testament to a great product and a great audience, and we're really, really, really proud. So to our Williamsburg family, we thank you. And to our Williamsburg Discovery Society members, boy, are you inspirational, and thank you. Your participation makes a difference. We thank you for your membership. We thank you for renewing. And for those of you who have not joined yet, please join us. It's valuable, you'll find it rewarding, and we couldn't do it without you. But I tell you, we're really proud of our VCU Health. We've got an incredible hospital, we've got great clinics, we've got an unbelievable history, we do unbelievable things today, and our future is incredibly bright. What we experienced tonight about our life-changing research and discovery, our unbelievable doctors, our nurses, our technicians, our deans, our teachers, our researchers, our support staff, and our administrators. We are truly blessed. Denise and Cheryl, please stand up, our ASAP superstars. These two, trust me, a lot of people think they run the hospital. I need to say no more. But I want you to know that we're here for you, and we're there up in Richmond for you, for your loved ones, for your friends and your associates. We also want you to know we're committed to Williamsburg. We're going to continue with great programming for you. And we're also going to do things for you to bring you up to Richmond to be part of the MCV Campus and the VCU Health experience. But we couldn't do this without the tireless efforts of this host committee. You've already been recognized. We thank you for what you do. A lot of you are here because it's friends helping friends and friends knowing friends. And I would especially like to recognize Judy Forehand Woods Starkey, and Charles Crone, who have been at this since the beginning. So rather than keep you from a drink and great food and a chance to meet with this great panel, let me remind you, when you leave tonight, there'll be packets outside. Please pick them up. For those of you who are already members of the Discovery Series, there's a renewal form in there for you. And those of you who aren't members, please sign up and join us to be part of our group. We're 115 strong, and we're growing. We're growing great. So my apologies for going so long, but I will tell you, this is exciting. It is a privilege and honor and a pleasure. And I can say this, it's successful because you folks want to ask more questions instead of going in there and eating and drinking. That means it's a good product. Let's go eat and drink. Thank you, guys. Thank you very much. Good night.